Today we're going to discuss about the radiology of pediatric abdomen. So what we will cover is abdominal radiograph, ultrasound, some of the fluoroscopic study that I'll mention afterwards, and also CT scan. So what are the indications for imaging in abdomen in pediatrics? Okay, normally we will start with abdominal radiograph. The child will come in with an abdominal distension, and clinically the clinician will suspect whether is there any bowel obstruction or you will suspect any bowel perforation. So abdominal radiograph is one of that indication. And often when you see a neonates, and this is very surgical alarming, whenever the child presented with bilious vomiting, so you need to exclude presence of duodenal obstruction, so you will do an abdominal radiograph. And at the same time, ultrasound is readily available and without any radiation exposure. So most of the time, ultrasound is also one of the first sign of investigation in cases that you suspect abdominal mass or patient with suspected pyloric hypertrophic pyloric stenosis. So meaning patient will come in with a non-bilious vomiting, often in neonates, yeah, and also those patients that we suspected to have intussusception. Whereby in contrast study, so contrast means that we give dye and we insert into the lumen, any lumen. So it can be in the GI tract or it can be in the genitourinary system, through the opening of at the skin. So it can be through the oral or from the anus or through the urethra. Now, whenever we see a double bubble on abdominal radiograph, so that will be an indication of a contrast meal. We'll discuss that, what are the disease that's associated with that. And whenever you see a multiple loops of dilated bowels on abdominal radiograph, then we will do a contrast enema, because basically we know that the pathology would be much lower, okay, towards the distal, towards the area of the large bowel. So that's what enema comes from, okay. And of course, whenever we do an ultrasound and then we thought we see a hydronephrosis, then we will subject the child for an MCU for us to exclude certain diagnosis. I'll show you later. And CT, since it has quite a high number of radiation exposure, so we will only preserve CT scan whenever we saw something on ultrasound, for example, a mass. So we want to further characterize the mass, or the surgeon wants to go in, so that's why we will do a CT scan to further delineate the lesion and also the associated infiltration, especially in malignant lesion. Okay, let us go to the abdominal radiograph. Most of the time, you will do an anteroposterior radiograph. Why? Because the child or the patient is at supine position, and this is basically applies in almost all the examination in pediatrics. And anteroposterior, because the image receptor is at the back, okay. And definitely we're not going to do an erect position, especially in neonates or even in toddlers, right? Okay, so most of the time will be in supine position. So whenever you receive a normal abdominal radiograph, you have to decide, is this really normal or is that abnormal? So in a normal supine abdominal radiograph, this is how it looks like, okay. So you have a soft tissue that represents liver, this is stomach, the airfield, and part of it is the spleen, and then you see there's multiple air loops of bowel. Most of them are polygonal in shape, and it looks near to each other, okay. There's no separation in between, and in this case this is a child with an angio tube, and also we know that it is an infant or it's a neonate because the umbilical cord is still present, okay. Whereas in erect position, which we normally do in cases that is much older age group, so we know that air will go at the non-dependent area, so you will see that the stomach air is going to be slightly higher, and you see all the liver and the kidneys been pushed or it's been descent just because of it is in erect position, but that's normal. Okay, this is how a fecal loaded rectum looks like. Okay, so that's not a mess. Now, whereas in idiocupitous abdominal radiograph, this is a specific radiograph that we only do whenever we suspect there is presence of pneumoperitoneum. This always, most of the time, we apply in NICU, in NICU. So what we do is that we do a left lateral decubitus. The child will be turned to the left side, and we have to wait for a few minutes before we acquire the image. Okay, what is the purpose is that whatever the air that goes at the non-dependent front of the intra-abdominal cavity will then track towards the lateral side, because of it's still at, this is the most non-dependent portion, and then hopefully if you can see the air, it's actually an extraluminal air outline. So this is how it looks like on a radiograph, and this is the air, extraluminal air, pneumoperitoneum that outline the liver margin. Okay, now, so sometimes we don't have to turn the child, so we can just do a lateral dorsal decubitus. That means the image receptor is still at the side, compared to previously this one. The image receptor is at the back here, because patient is turned. But if the patient cannot be turned, there's a lot of lines, so the image receptor is at the side, and the mobile X-ray projection is from the side, the other side, and then we call that as a lateral shoot through. So we don't have to immobilize the patient, and you will see the air is actually at the position where it is. So it's a lot more easier, especially when patient is cannot be moved because of lots of lines. So whenever you have to interpret a pediatric abdominal radiograph, you need to know the normal bowel gas pattern. That is basic. Okay, whenever you know that how is the normal bowel gas pattern looks like, then definitely you will recognize whenever there is an abnormal airfield bowel distribution, or an abnormal soft tissue, or even calcification. Okay, so whenever you see an abdominal radiograph in a pediatric age group, age is important, because we know that with the changes of an age, there would be different in the food consumption, so it will affect the pattern of the feces that presents in the bowel. Okay, and with age, the loops of bowel patterns also changes. I will show you afterwards. And of course, the body and organ sizes will be different, right? So, and therefore the disease and pathology will also be different, because whenever the child is slightly younger, we know that the differential diagnosis is related to something congenital, intrauterine. But as the child goes older, then some of the acquired diseases will happen. All right. Now, for a normal bowel gas pattern at birth, when the child went out from the womb, then you will see the gas in the stomach if you happen to take an radiograph at the time of the birth. Okay, 1 hour later, the gas chute has propagates and advanced into the proximal small bowel. 6 hours then it will go to the distal small bowel. Okay, so within 24 hours you should see the gas in the large bowel. Okay, so whenever you receive an abdominal radiograph and the child is at 12 hours, for example, and you only see an air that outline the stomach, then you know that is abnormal. Okay, and as I mentioned earlier, it should be polygonal shape, distributed all over the abdomen. Okay, however, in neonates, you are unable to distinguish between large and small bowel. So this is what I meant when the normal bowel gas pattern changes with age. Okay, so at the age of day 3 of life, you can't really say where is the small bowel and where is large bowel. Maybe you can predict, okay, the more center is the small bowel, but the more peripheral is the large bowel, but the pattern, the shape is indistinguishable. Okay, as later on you will see it becomes, the haustra becomes to be seen, and of course you don't see much of the feces, but by 4 years old you do see feces, because child has been eaten so many things. Okay, so you will see that, and then by 11 years old, you will see it's as if in a adult pattern of a normal abdominal radiograph. So in this case, you see an air field turn the colon. That's a spleen reflection. It's very well delineated, and you can actually differentiate between the large and the small bowel. So for you to interpret an abnormal abdominal radiograph, identify the abnormal gas collection, okay, or is there any abnormal density to suggest soft tissue or calcification. So and when you see an abnormal gas collection, you have to decide whether the gas is intraluminal, which most of the time implies to bowel obstruction. If the gas is extraluminal, whenever you have to diagnose that as a pneumoperitoneum, surgical emergency, because you know that there would be an associated bowel perforation. And if, let's say, the air is in the wall of the bowel, that is an abnormal intramural gas collection, and most of the time it's associated with bowel ischemia in cases of necrotizing enterocolitis. Now, whenever you see an extraluminal air, so for example, in this case, you have a very huge air at the center. This is what we call the football sign, and then you'll be able to see that the air is actually under the diaphragm. Often you don't really see that if it's in supine position, but if it's very big, very huge pneumoperitoneum, you definitely see it. Okay, and then you have the visualization of the falciform ligament like this one. Okay, and one of the things that three major features that you will see in pneumoperitoneum commonly seen is double wall sign, which is you can actually see air in with here, and the wall is being sandwiched by air intraluminally and also air extraluminally. So that is what we call regular sign. And then you will see a loss of liver capacity. This is all normally happening in neonates, because neonate has a small body build, so whenever a small portion of air extraluminally, then you definitely see it's a very big one, okay, related to body size. Okay, so what about this one? So, well, you see, you do not see a loosened liver, okay, not too bad, but here you're not sure whether is there any regular sign, and that has sandwiched the wall, whether wall is intraluminal here and extraluminal outside. So we are suspecting a pneumoperitoneum, but not as convincing as the other radiograph just now. So like in this case, you might want to do a lateral decubitus or a lateral shoot through, just for you to get a clear demarcation whether is this a pneumoperitoneum or not, and in this case it is a pneumoperitoneum. Okay, so always identify and outline this air, whether is this a normal air in the large bowel, in the bowel, or it is an extraluminal air. You have to understand or know what is the anatomy of the normal distribution of the bowel before you can reach to the conclusion of saying that it is abnormal. Like in this case, it looks that it's projected outside because it does not conform to the shape of the bowel. Okay, so this is another example of peritoneum. When you see an air in the lumen, but the lumen is abnormally dilated, so think about bowel obstruction. And when you have a bowel obstruction, you need to decide whether this is a proximal bowel obstruction or a distal bowel obstruction. What I mean by proximal, I'll show you afterwards, because when you see a proximal, then you have to know whether it's a single bubble or is it a double bubble. I'll show you afterwards. Okay, because the treatment or the imaging modality that will help in confirming the diagnosis will be slightly different, or you can do both. If it's distal bowel, then you might want to do contrast enema. So contrast enema is a contrast through the anus into the rectum, compared to contrast male, which is a contrast that goes through the oral from above. Okay, so decide whether is the bowel dilated. So normally you have to look at the spine here, the vertebral body, and then look at the interpedicular width. For example, in this case is L2, and then compare that with the airfield bowel that you see. If it's more than that, then the bowel is dilated. Okay, so if it's massive, you know that it's a complete obstruction. It's not that very iffy, then it might just be an ileus or a subacute intestinal obstruction. Okay, so if you have a fluid level, then it will indicate that maybe there's abnormal peristalsis, the bowel is ischemic, bowel is not moving, so that's why all the air and fluid is mixed to each other. Another way to look at the bowel ischemia or stagnant look that's not moving in more than one abdominal radiograph, consecutive abdominal X-ray. Have a look, is there any stagnant look, because you have to suspect if there is evidence of bowel ischemia. Okay, that also indicates absence of peristalsis. So I mentioned earlier the normal polygonal shape of a bowel, meaning the wall should be in a close proximity to each other. But whenever you see a separation of bowel, okay, between the bowel wall, then you have to think about whether is this a distended bowel movement, or is there any fluid, interloop fluid that goes in between, for example in ascites, cases of ascites, or even if the wall actually thickened. Okay, I did mention about the proximal and the distal bowel obstruction. So how do you decide that? Is by looking at the number of dilated loops. So basically, if it's up to 3 dilated loops of bowel, then we will say that this is a high obstruction. Like in this case, we have 1, maybe 2, and 3. So 3. So it is a high obstruction. So you know that the differential diagnosis would be something higher. And if it's more than that, so this is definitely more than 3, then you have to think about low obstruction. So why is it important? No, because normally patient that comes in with a proximal or high bowel obstruction, they will come in with a bilious or non-bilious vomiting, because we know the pathology is somewhere higher. Okay, so that means it covers from the stomach down to the ileum. Okay, but normally those patients with a lower bowel obstruction, they will come in with abdominal distension, failure to pass meconium in units. So because the problem is distal, so it is more towards at the distal ileum and also involved the colon. Okay, because the differential diagnosis is slightly different. Okay, if it's in higher obstruction, you have to think about stomach or duodenal or midgut abnormality, okay, pathology. But if it's in a low intestinal obstruction, you have to think about the more distal small bowel involvement or a large bowel involvement. Okay, now what about this one? So this is obviously a single bowel sign on an abdominal radiograph, because whenever you have a single bubble, you have to think about hypertrophic pyloric stenosis. What is that? It's actually a thickening of the pylorus. So this is the antrum of the stomach, and this is the first part of duodenum, and you have a pylorus in between, which is a channel that communicates the stomach into the duodenum, right? But normally the pylorus will not be thickened, but there are congenital abnormality whereby this pylorus muscle is thickened, and it has caused stenosis to the to the distal stomach, and that's why the child will be presented with a non-bilious vomiting because of the obstruction that happened at the pylorus. So hypertrophic pyloric stenosis. So often we don't really do a contrast study because ultrasound is superb or fantastic to show that the pylorus is thickened, and we have certain measurement to measure the thickened pylorus. And of course, because if this is ultrasound, it's very dynamic, so we can actually assess the stomach content, whether the stomach content, once the child is drinking, and whether the milk has gone and passing through the stomach at the pylorus or not. So definitely you'll be able to see that any delayed stomach emptying, and also of course the stomach is the standard. In this one, of course, you see more than one. So you have one bubble and two bubbles. So double bubble, okay, double bubble sign. So double bubble sign, you have to think about a duodenal obstruction. In cases of duodenal stenosis, duodenal atresia, or even the more alarming surgical emergency, which is the midgut volvulus. Okay, midgut volvulus that is most of the time is because of malrotation. Okay, some abnormal congenital embryological abnormality related to the midgut. So in a normal contrast meal, okay, contrast meal, basically you will outline a normal stomach and you can actually see the rugae there. That's the antrum of stomach with a D1 and D1 here, and of course you will see this is the C lobe, which is presented by the duodenum. Okay, that's the second part, and we know that the biliary system will goes and drain into the second part of duodenum, and you have the third part of duodenum that crosses the midline, and this is the duodenal-jejunal junction before it goes and becomes a jejunum. Importantly to note that the DJ junction should be at this point. It is at the level or just at the level of the D1. Okay, it should not be here. It should not be here, because this is a normal anatomy, and we know pancreas is being enveloped at that point. Okay, so whenever there's abnormality to that, that means there is abnormality related to the rotation of the gut embryologically, and here is where the axis of the superior mesenteric artery present. So the midgut rotation is solely depends on the axis of the SMA. Okay, so if that is not normal, so that appearance does not present, like in this case, you will see, okay, the stomach and then the duodenum, okay, but then the D3 does not cross the midline to the DJ junction, but instead it gives rise to this, a corkscrew appearance, right? So like this one, okay. So in the case of a corkscrew sign, okay, dilated stomach and proximal duodenum, but you do not see any opacification of bowel distally, that means this is a midgut volvulus, surgical emergency which has to go in, because the twist is related to axis of the SMA, and when this happens, obstruction, there is no blood supply going to the bowel, and the bowel gut is ischemic. So that's why it's surgical emergency. So this is much related to the understanding of the embryology of the midgut. Okay, so we understand, during at the 6th week of gestation, the bowel starts to develop. This is the primary intestine. This is the vitelline duct. It goes and herniate extra amniotically, okay, outside, as it elongates, and when it's actually outside here, it starts to rotate 90 degrees at first. Okay, and anything that is so this should be the proximal bowel, and this is the distal bowel. So and this vitelline duct. So when it's rotated, as it started to enter back the abdominal cavity, it rotates another 180 degrees. Okay, so at this point, the cecum is at the right hypochondrium, and so that's the splenic flexure. But later on at birth, the cecum will start to descend, and this is when the cecum becoming at the right level side. Okay, so if ever all this process being halted, okay, being obstructed, disturbed, so that is when the malrotation happen, because all this rotation is at the axis of the SMA. So because we know the SMA will come and then supply the bowel until the 2/3 of proximal of the transverse colon part. So if it's abnormally rotate, then the malrotation happen. Okay, so when a normal SMA happen, okay, rotation happen. So So remember the J fracture that I showed you in the contrast mean earlier. So that is when we know the axis of the SMA should be. So it should runs from there, and then it goes towards the ileocecal valve. And if you draw it, it looks like a smiling face. Okay, not a face, a smiling mouth. Okay. However, if there is a malrotation, the mesenteric axis is shortened. So, for example, in this case, you see the point between the DJ flexure and the point between the DJ flexure and the ileocecal valve is shortened, and you see it's very shortened. It's not smiling broadly just now, so it prone to get rotation, twisted because of its shortened. Okay, so that's when the mega volvulus happen. So in mega volvulus, this is what it portrayed. So a short mesentery give rise to an easier it's being twist. Okay, and that vessel is within here, so that's why the vessel is also compromised, causing bowel ischemia. Okay, so normally we do an ultrasound for the child, and then we see the SMA, where the position of SMA is normal or not. And at the same time, we will see the whirlpool sign. That means the SMA has been twisting because of the abnormal volvulus. So it looks like a whirlpool sign, like this one. Okay, now if you see a dilated bowels and it's multiple, so you know that this is something more distal, then it is a low obstruction. Okay, so what can be the cause of multiple lobes of the dilated bowel? Islet atresia, it can go as low as at the rectum level, rectosigmoid in cases of Hirschsprung disease, or it can be an intersection whereby there is an ileocolic herniation. Okay, intersection. Now, in low contrast study, low bowel obstruction, we will do a low contrast study. Why? Because we want to delineate what is happening in the colon. Okay, if the colon is like this, you can remember that the bowel just now is so dilated. Okay, then you do the contrast element, where you introduce the contrast into the rectum, and then it goes and opacifying this large bowel, and you see that the bowel is small, a large bowel that's supposed to be large but it's small. Okay, and then there is filling defect here that represent the meconium palate. So you know that there is obstruction in between this dilated bowel and the junction. So in this case, we advance the contrast more, and then it reaches the ileocecal valve into the terminal ileum, but still it is microcolon. So we this is a characteristic findings of a low bowel obstruction in the cases of meconium ileus and also islet atresia. Okay, so intraoperatively, definitely you will see that the more proximal bowel is so dilated, it looks as if it's almost gangrene, because there's some blood compromise, but the more distal one is collapsed. Okay, just because there's an atresia, a trachetic portion in between. Okay, so when you see about a more dilated bowel, patient comes in with abdominal distension, and one of the common presentation would be no meconium for the past 24 hours. So he has not been passing meconium since birth. So, and you can notice that at the region of the rectum here, you do not see an air. Okay, there's absence of air in the rectum with a multiple dilated lobes of bowel out there. Then think about a more distal bowel obstruction, for example, in the rectosigmoid colon. So in the case of Hirschsprung disease, because if it's low bowel obstruction, we will do a contrast enema. So we did a contrast enema, and then you will see a transition zone. Suddenly, this is the rectum, and suddenly it tapers. After that, it becomes a bigger caliber, just because the more proximal bowel is so dilated and there is a abnormal aganglioid cells in the region of the transition zone, and after that become a rectum. So that's why patient has obstruction. Okay, so another features would be the abnormal rectus-sigmoid ratio, but I think as long as you know that the contrast will show a transition zone at the region of the rectus-sigmoid junction is good enough, because that is one of the way of us to diagnose H-point disease. Alright, okay, so this is a much older child, alright, coming with abdominal distension, abdominal pain, and then you see this multiple dilated loops of bowel on the abdominal radiograph. You do not see there's a paucity of air filled bowel more inferiorly, more distally, no air in the rectum. So what can be your differential diagnosis? Well, in a 3 years old or 4 years old, think about differential of intussusception. It can be appendicitis, and appendicitis can happen at any age group. Normally it's 3 years and above, or think about foreign body ingestion as well, because most of the foreign body is not opaque. Okay, now this is a schematic diagram of intussusception. Intussusception means that there is a telescoping of a small bowel, which is the ileo, into the large bowel. So this is the cecum. Okay, that's the appendix. So cecum as the recipient, the intussuscipient, where the ileum is the intussusceptum, and it telescope into, because the bowel is still immature, so it's mobile, and that's why the intussusception happen. Okay, so but as a consequence of this, that it will create an intestinal obstruction. Okay, so when we do an ultrasound, most of the time you will see the bowel is within a bowel. Okay, so then this is what we call as a pseudo kidney sign, because you know that this is the normal kidney. Okay, that's the liver. So this is the intussusception is at the region of the hepatic flexure. You can imagine sometimes the ileum can go up to the rectum, so but it's still an ileocolic intussusception. So it resembles like a kidney, but it's not a kidney, so we call that as a pseudo kidney sign. Okay, so what we do, we don't have to send the child to OT, to operation theatre stat, but what we do, we will do an manual reduction using an imaging before. If it's failed, then we send for operation. So what we do in our center in UCAM, we will insert the rectal tube, and then we will into the rectum, and then we will introduce saline. Okay, saline, because the saline will help to give pressure, and we will push this particular ileum back through the ileocecal valve into its normal position back. Okay, so so this is the ileocecal valve. Okay, so that's a thickened ileocecal valve, but whatever it is, whenever we have not seen this particular ileum anymore at the region of the cecum, and it has gone through this particular ileocecal valve, then we are sure that the intussusception has reduced and everyone's happy. Okay, no need operation. In other centers where they do not do any ultrasound guided saline reduction, sometimes they will do a fluoroscopic reduction, and this fluoroscopic reduction is basically, the basic is also introducing something which is air, and this air is been given a pressure, so that particular pressure of air pressure will push the ileum back to the normal position through the ileocecal valve. Same principle, but different materials being used, and as well different imaging modalities being used. In saline guided, ultrasound guided, we will use ultrasound, no radiation, but in fluoroscopic guided, they use a fluoroscopy, and it involves radiation. Okay. Now, okay, so we have done with air outside the lumen, air inside the lumen but dilated. But now we are going to go to an abnormal air that located in between, which is in the wall of the bowel. Okay, so like in this case, if I make this image bigger, you can actually see there's a linear lucency here that you feel that it's very busy around that region. And if you outline that way, then you have to suspect if that linear lucency is actually air in the bowel wall. Okay, so this is what we call intramural air. Sorry. So as I state, intramural air can be seen as a linear lucency. It's lucent because it's air. Okay, and it goes along, occupying the bowel wall, and also it can, whenever you see that as an end-on, okay, you might see that as something that is like a soap bubble appearance, busy like air locules, okay, but it should not be that appearance. Okay, so these are the signs of intramural air that often been seen in a case of necrotizing enterocolitis. So patient with prematurity that is more prone to get that. So but if let's say it can have a complication, and like in this case the patient with NEC develops a pneumoperitoneum. So that is basically the complication that you have to understand that can arise from a case of intramural air. Okay, so basically intramural air indicates bowel ischemia. So bowel is become thinning and then it perforates, so it will introduce air extraluminally. Okay, so this is just an example of normal versus abnormal. Okay, whenever you have a case with a suspected intra-abdominal mass, so the first line of investigation would be an ultrasound. Why? Because we definitely will be able to see things. For example, in this case, you will see a mass. This is at the suprarenal on the right side, so that's the liver, that's the air-filled bowel, stomach, sorry. So when you do another view, which is at the sagittal view like this one, you will see that this is the kidney, and there's a mass at the superior portion of the kidney, which is suprarenal. So in a patient with the age group of 2 to 3 years old, always think about neuroblastoma. So in this case, we send this child for a CT scan because, as I said, that is an indication for abdominal mass. Then you further delineate that thing and you definitely see some density which represent the calcification. And if you go down, the kidney is okay, it's normal. So neuroblastoma. So causes of intra-abdominal calcification, the most common would be neuroblastoma. It can also be a teratoma. Okay, any teratoma will produce a calcification. Or if you see a calcification in an abdominal radiograph of a newborn baby, think about meconium peritonitis, meaning the bowel is has perforated intrauterine and is sealed, and then the meconium that goes outside in the peritoneal cavity calcified. So that it gives rise to the meconium peritonitis, like in this case. Okay. Now, abdominal mass. Okay, you palpate and you feel there's a mass, for example, on the right side. Okay, ultrasound. So when you did ultrasound, you see, okay, this is quite a huge fluid-filled cavity. So where is this actually? So by anatomy, we know that this is at the region of where the kidney should be, but we do not see a normal kidney. So that means this kidney is abnormal and is split-filled, which is indicate severe hydronephrosis. That's a comparison of a normal kidney. So you should see a very good pyramids as well as the cortex, and that's the renal sinus, which is brighter because it contains a bit of fat. But if you lost all this and instead you see this, then it is a severe hydronephrosis. Whenever we see this in a child, we have to think about obstruction related to genitourinary system. So, for example, in pelvic ureteric obstruction, PUJ obstruction, or sometimes if you see a dilated ureter at the same time, you have to think about obstruction more distally or abnormality more distally. So in this case, we subject the child for a contrast study, which is the micturating cystourethropy (MCUG), and we introduce the contrast in the bladder, okay, the dye in the bladder, and a normal study should not show the ureter because we have a valve in between the ureter and the bladder. But in this case, the valve is immature, is abnormal, then there is a reflux, and that's what we call vesicoureteric reflux. And in this case, it's very huge. It reflux all the way into the renal pelvis, and that's what we saw that as a hydronephrosis just now. Okay. Now, just to touch on the anatomy of the vesicoureteric junction, we know that ureter will goes and it will pass through the muscle of the wall of the bladder, which acts as the valve as well. But if there is some abnormality around this region that this does not function as a valve, then the vesicoureteric reflux will happen. Okay. Now again, abdominal mass. So what's the imaging modality of choice? Ultrasound. Now, so whenever in this case we did an ultrasound and we saw there is not a fluid, okay, not black just like just now, but instead it looks like a soft tissue, okay, slightly bright, not black, in a kidney. In this is the left kidney, because you see this is the kidney and that's the renal sinus, but the renal sinus and parenchyma at the inferior part is being disturbed with this mass. Okay, you see that the mass is rising, so this is what we call the claw sign. Okay, the claw sign, like a claw. And true enough, this is a CT scan actually showed that the mass is originating from the left kidney in a case of Wilms tumor. Okay, common tumor that happens in toddler. All right, so mass majority you see it's retroperitoneal in origin. If it's cystic, it's fruit-filled, it's anechoic, it's black in color, at the region where the kidney should be, then suspect of hydronephrosis, then we do an MCUG to look for reflux. But if it's solid, it's slightly hyperechoic and hypo, on ultrasound at the kidney, it can actually be Wilms tumor, or it can actually be the suprarenal, which is the neuroblastoma. So we will do CT for staging of the disease. Okay, so as a conclusion, whenever you approach an abdominal radiograph, always have a systematic approach, systematic analysis of it. Look at always put inside your brain that what is the normal abdominal radiograph looks like in this age group, and then when you know that normal, how does a normal look like, then definitely you will identify the abnormal gas collection, extraluminal, intraluminal, intramural, or abnormal calcification. Then you have certain differential diagnosis, and of course think about further imaging study that can be really be done, be it ultrasound, contrast study, or CT scan based on your differential diagnosis. Okay, now so with that I thank you.